Hey everyone, this lesson is on Hashimoto's thyroiditis. So in this lesson we're going to talk about what are some of the causes of Hashimoto's thyroiditis, who is at risk for getting this condition. We're also going to talk about how we can diagnose it and how we can treat it. So Hashimoto's thyroiditis is a chronic autoimmune thyroiditis causing a primary hypothyroidism due to a cellular and humoral mediated destruction of thyroid tissue. So key points to take. It is an autoimmune condition that causes primary hypothyroidism. It is, in fact, the most common cause of hypothyroidism, at least in the developed world. And like many other autoimmune conditions, females outnumber males with this condition. Generally, the ratio is between 7 to 1, so 7 females for every 1 male. And it is such a common condition that it is estimated that up to 10% of the general population has this condition, and interestingly, it actually increases with increasing age. So the prevalence of Hashimoto's actually increases with age. So the older you get, the more chances you could get Hashimoto's. So this is a significant condition. So how are we going to remember that Hashimoto's causes hypothyroidism? Well, I want you to think about the phrase Hashimoto's hacks up the thyroid gland. Hashimoto's hacks up the thyroid gland. And picture an axe, and you're essentially just chopping up a thyroid gland. And if you have a chopped up thyroid gland, if it's hacked up, well, it's not going to be functional. It's going to be hypothyroid. So that's how you're going to remember that Hashimoto's causes hypothyroidism. Hashimoto's hacks up the thyroid gland. What are some of the risk factors of Hashimoto's thyroiditis? The risk factors include genetic conditions. So it's interesting that individuals with Down syndrome and Turner syndrome have an increased prevalence of Hashimoto's in general. Now, there's also associations with the gene HLA-DR3, because this is an autoimmune condition. And interestingly, if you actually see a family member who has Graves' disease, which is a condition causing hyperthyroidism, well, you're at more risk for actually having Hashimoto's. They're both autoimmune conditions, so they generally run together. Other interesting risk factors include having stress. So increased stress seems to be associated with the onset of this condition. Again, family history. This falls in line with genetic conditions and genes. Gender, as we mentioned before, being female is a big risk factor. In fact, it's 7 to 1 compared to males. A high iodine consumption or high iodine diet can actually increase your risk for having this condition. So it's been shown that having actually a bit of a lower iodine consumption diet, so a bit on the lower side, may actually reduce the risk of having this condition. And there's also a question of, well, does cigarette smoking cause this, or does some kind of infection cause this? It's not quite known. So there are actually a couple subtypes that I want you to just know about. These are really not that important for this lesson, but the subtypes for Hashimoto's thyroiditis include a goitrous type. So the person generally has what we describe as a rubbery thyroid. So they have euthyroid condition that progresses to a hypothyroid condition, and it's due to fibrotic changes. And the other condition is atrophic. This leads to hypothyroidism and is associated with the thyroid lymphoma. So the two conditions, because this is an autoimmune attack on the thyroid gland, we're either going to have a basically shriveled up thyroid gland like you might see in atrophic subtype, or you're going to have fibrotic changes, scarring, which is going to cause a rubbery goitrous type Hashimoto's. So these are the two conditions I want you to think about. So what actually causes Hashimoto's thyroiditis? What is the pathophysiology? So in order to understand what happens in Hashimoto's thyroiditis, it's important to know the general basic endocrine signaling pathway of normal thyroid functioning. So generally, in a normal thyroid or a normal patient, healthy patient, no thyroid issues, the hypothalamus releases thyrotropin-releasing hormone, TRH, which acts on the anterior pituitary to release TSH, thyroid stimulating hormone, which then acts on the thyroid gland to release T4 thyroxine and T3 triiodothyronine. Both of these hormones can relay back, so a negative feedback inhibition on the anterior pituitary gland to reduce the level of TSH, and they can also feed back on the hypothalamus to reduce the level of TRH. So in a normal functioning thyroid, we're going to get release of these hormones in response to TSH, and these hormones are going to have a negative feedback loop on both the anterior pituitary and the hypothalamus to both reduce levels of TRH and TSH. That's the normal thyroid functioning. And T4 and T3 are so important because they're responsible for the M's. And the M's are movement, mentation, and metabolism. So we need to metabolize, we need metabolism to survive, we need to think, we need mentation, and we need to move around. So these hormones are super important. So what happens in Hashimoto's? Well, Hashimoto's is essentially due to a defective T cell suppressor. I'm not going to get into all the details here, but essentially you want your body to suppress T cells that can target its own cells, right? And what happens is there's a signaling cascade that leads to cell-mediated destruction of thyroid follicles, and T cells can lead to the activation of B cells, which can lead to the production of antibodies against a variety of components within the thyroid gland, like thyroglobulin, thyroid peroxidase, TSH receptor, and the sodium iodine symporter. So essentially, because of all these antibodies and the cell-mediated destruction and attack on the thyroid gland, Hashimoto's essentially, remember, hacks up the thyroid gland. We're going to lose the thyroid gland. We're not going to be able to produce T4 and T3. These hormones are going to decrease in concentration. They're going to decrease in levels. And because we lose T4 and T3, we're going to lose the negative feedback regulation on the anterior pituitary and the hypothalamus, leading to increased TSH and increased TRH. And because the body sees that, why is the thyroid gland not doing what it's supposed to do, it's going to try to actually pump out even more hormone to get it to function. So that's why we're going to see all of these responses to the attack on the thyroid gland. Again, low T4 and T3, a high TSH, and a high TRH. Hashimoto's essentially presents with signs and symptoms of hypothyroidism. And the thyroid gland, as we mentioned before, produces T4 and T3, which are responsible for mentation, movement, and metabolism. So all of these are going to be reduced in function. So if we were to take a broad look at a patient with signs and symptoms of hypothyroidism, they're going to have hair loss, they're going to have coarse and dry hair, they're going to have dry skin, and they're going to have periorbital puffiness. They're also going to have decreased what we call mentation, right? So we're going to have decreased mood, they're going to be depressed, they're going to be fatigued. They're also going to have, because they have reduced metabolism, they're going to have a weight gain, they're going to have intolerance to cold, they're going to feel cold, hypothermia, they're also going to have muscle cramping, they're going to have pallor, they're going to have bradycardia, so reduced heart rate, and they're going to have delayed reflex relaxation, so the delayed deep tendon reflexes. And other signs and symptoms of hypothyroidism include constipation, so the GI system is basically slowed down, so they're going to become constipated, they're going to have menstrual abnormalities, and they're also going to have galactorrhea because of the TRH increasing levels of prolactin. We didn't talk about that, but that's just an important thing to recognize. Now, how do we make the diagnosis and how do we treat Hashimoto's? Well, we basically, since we've got a good understanding of the pathophysiology of Hashimoto's and normal thyroid functioning, it's pretty easy to diagnose this. In fact, we've already talked about it before. If we see a high TSH and a low T4, we can say the patient has hypothyroidism. And if you're thinking, well, maybe is it Hashimoto's or maybe it's some other cause, well, we can dig in a little bit deeper to measure some of those antibodies we talked about before. One of them that is typically assessed is the anti-thyroid peroxidase, and this will be elevated in Hashimoto's. And you could also look for thyroglobulin antibodies. So again, the diagnosis is going to be with a high TSH and a low T4. That's essentially hypothyroidism. And then if you're thinking it's an autoimmune condition, it's Hashimoto's, you want to order an anti-thyroid peroxidase. So how do we treat it? Well, basically it's pretty simple to treat this. Really, we want to replace what they've lost, and we replace that with L-thyroxine or Synthroid to essentially treat their hypothyroidism. They don't have enough thyroid hormones. They don't have enough T4, T3. We got to give it back to them. So that is how we treat it. So if you want to learn more about thyroid conditions like Graves' disease, please check out my endocrinology playlist. And if you haven't already, please consider liking, subscribing, and clicking the notification bell to stay up to date and support the channel. And as always, thank you so much for watching, and I hope to see you next time.